Hello, everyone, and welcome to our webinar today, Equity's Role in Social Determinants of Health Interventions, Advocacy and Systems Change. But before we dive into our discussion today, we would be remiss if we did not highlight the injustice of police brutality that is undoubtedly capturing our nation's attention today. Just like COVID-19, we must not only acknowledge but act to end the public health crises of police brutality and racism. And we must all understand the role we must actively play in ending this devastation. So now we would like to take a moment of silence to honor the lives of George Floyd, Breonna Taylor, Ahmaud Arbery, and Tony McDade, and the countless faces that we have seen or not seen fall victim to police brutality and racism daily. Thank you. Now, for those who may not be familiar with Health Leads is an innovation hub that runs both national and local initiatives that address the deep societal roots of racial inequity that impact our health today. During COVID-19, we've seen Black and Brown communities disproportionately impacted due to structural racism and white supremacy. Health Leads work has focused on helping communities both respond to immediate essential needs and rebuild equitable systems for the future. And as we begin to rebuild systems, we must ensure that we're not replicating or reinforcing the deep inequities in how those health justice and education systems operate. And we need to intentionally and explicitly uplift racial equity. So to center us into our conversation today, the illustration you see here was created by Health Leads and depicts the total demand for social services as compared to social service capacity over time throughout the COVID-19 crisis. Now, when you look at the curve, you can see the demand for social services far exceeds the social service capacity. Now, the story behind this curve is one of health equity. At baseline, the U.S. has large racial disparities across health outcomes, food insecurity, income, and access to adequate housing and education. And as we are experiencing now unemployment that some says rivals numbers of the Depression, we only have to look back at the 2008 recession where we saw unemployment across race, gender, education level vary greatly. For example, whites had unemployment rates reaching that of 9.1%, whereas blacks had rates reaching that of 16.8%. Therefore, we must rebuild with a racial equity lens. Otherwise, the aftermath of COVID-19 will continue to disproportionately impact Black and Brown communities. Archbishop Desmond Tutu states that if you're neutral in the situations of injustice, you have chosen the side of the oppressor. This means that we cannot just do well-intentioned efforts to elevate racial equity. We must be explicit in elevating racial equity even in how we integrate social care into clinical care delivery. We must examine if our work is truly addressing root causes of inequity and that we're making sure that we're advancing the cause of dismantling structural racism and white supremacy. And everyone is needed for that cause. We need allyship, And we also must yield power to people of color to lead. And we have to center these communities of color in our social determinants of health work. And that's what we're here to talk about today. So in today's discussion, we are very fortunate to be hearing from 3 health equity champions, and we will be sharing recommendations that you can apply to your work. So first, we have Dr. Rhea Boyd. Rhea is the Chief Medical Officer at San Diego 211, and she's a clinician at the Palo Alto Medical Foundation. Rhea has been able to intertwine her clinical work with advancing community-based advocacy. And Rhea will talk about that intersection and provide us with her experience of how she connects her work in the social determinants of health sector to addressing root causes of structural racism, particularly for Black and Brown communities. Next, we have Dr. Daniel Jones. Dan is the Sanderson Chair in Obesity, Metabolic Diseases, and Nutrition, and he's also a professor of medicine and physiology at the University of Mississippi Medical Center. Dan will talk about his work, particularly in research, and his personal journey to become a stronger ally to uplift public health and social determinants of health issues affecting communities of color. And lastly, we have Dr. Lauren Powell. Lauren is the founding executive director at Time's Up Healthcare and the president and CEO of the Equitas, LLC. Lauren brings the political perspective to our panel today. She previously led the Office of Health Equity for the Commonwealth of Virginia's Department of Health Equity, or for the Commonwealth of Virginia's Department of Health, And she understands how social determinants of health interventions and public health work can be used to foster advocacy efforts and political change. So throughout our discussion today, please chat in any comments or questions, and we will address them during the Q&A at the end of the webinar. But with that, let's dive into our conversation today. So as individuals or groups seek to create systems or policy change, situational awareness or institutional awareness is essential to explore. Power dynamics are important components of situational or institutional awareness that are important to name, and more importantly, it's essential to strategically address them. And we've seen how power dynamics enter the social determinants of health and social needs sector as well, as we do not typically see members of communities of color, especially Black and Latinx folks, serve as the key designers of social determinants of health interventions. Even more so in our community partnerships to address social needs, we often overlook partnering with smaller, more grassroots organizations who may not have had the resources to do the evaluation or the publishing work to highlight their work or programs as best practices. So with that, Rhea, Lauren, Dan, can you share other types of power dynamics you have had to address as you have sought to tackle structural or system change? And Rhea, I'm hoping that you can open us up.
Absolutely. First, thank you again for having me on this panel with this incredible group. What I'll say is that we often talk about, or we sometimes talk about, racial health inequities as if they are a glitch, as if they were a mistake where an individual could have acted differently in that scenario and the outcome could have been different. The problem when we talk about them that way is we miss the structural roots. We miss the systematic nature of racial health inequities, that it's not happening at the individual level only, it's happening at every level of the system, and that it's happening for populations, not just individual patients. What that means is we have to start thinking about racial health inequities as the byproduct of our systems functioning as intended. They're not a glitch, they're actually the systems working. What that means is if you want to address racial health inequities, the biggest power structures that you're up against are the power structures that are currently well served by the system working the way it does now. Sometimes in a healthcare system, that might be administration and leadership, whose roles are tasked with keeping the organization running, keeping the lights on, keeping the doors open. It's a very important role and one that's helpful. But if you're saying that the way that we're keeping the lights on and the way we're keeping the doors open, the actual business model of how we're providing healthcare is creating racial health inequities, then we have to rethink how we pay for healthcare, how the methods we use to pay for healthcare shape who receives that healthcare and what that healthcare delivery looks like. So those power structures go to the highest levels of our healthcare system. It centers healthcare administrators locally, but also policymakers nationally who shape broader pathways for us to pay for and deliver healthcare.
Thanks, Rhea, for sharing that. You know, as you talk about how we pay for healthcare, the business model, a lot of times when we are thinking through social determinants of health or social needs interventions, you hear about the return on investment. Particularly, are we seeing a return on investment for investing in addressing social determinants of health? And I would love to hear from you, just how do you think that narrative either perpetuates inequities or maybe exploits some of the structural racism that you say the system is designed to continue to perpetuate?
Yeah, so we hear this language a lot when you want to work in the equity space. People say, if you want your hospital or healthcare system to do something about it, you need to give them the business case, right? You need to give them the value case for addressing racial health inequities. But again, that's like a misreading of the problem. And here I'll quote Ruha Benjamin, who said, racism is productive, right? Racism actually generates value. When you can hierarchically order human beings and the resources that you give those human beings by race, that is how you power a capitalist system, that some people at the top get a lot and the people at the bottom get a little. Healthcare participates in that capitalist, profit-driven model. We tier our healthcare based on health insurance status often, and the data shows us that also tiers our healthcare based on your racial or ethnic affiliation. So when people ask for the business case, there is no business case to get rid of equity. The business case to get rid of inequities is counter to the business case that actually our healthcare systems are created around. And that's a hard reality that we all have to swallow. You can't provide equitably for populations and think that you're going to garner massive profits. Healthcare is a right, and we need a universal healthcare system so that everyone pays into and everyone benefits from those resources. As long as we continue to tier our healthcare system by those who can pay or those who have fancier employer-based insurance, we'll continue to see broad inequities that will continue to break out by racial and ethnic groups.
Thanks so much for sharing that. I want to bring Lauren into the conversation because of your perspective of advocating on the political level and just wanted to get your insights of the power dynamics you see in the work that you do.
Well, first and foremost, thank you for hosting this. Thank you for the opportunity to participate. And I want to thank Dr. Boyd for setting the stage so very well. You're absolutely right. You know, there are so many power dynamics that you're up against. I would say in the political government front, those dynamics are even more pronounced. And so when we think about a moment like this, like COVID-19, where we are so heavily dependent on state governments, because federal government is really not even to be mentioned in this, but the autonomy of response has been divvied to state government. And so thinking about the types of leaders we have, the mindset and the values of the leaders we have, and how that is embodied in the response in a moment like this. In Virginia, as I'm also working for Times of Healthcare, I also have some consultation in Virginia. And so Virginia is really trying to very much prioritize health equity in the response right now to COVID-19. For the first time ever, they've created a health equity leadership task force and really trying to work to ensure that health equity is a part of every single facet of this response and recovery moment. But in that, we face so many power dynamics. We face so many challenges because we are actually challenging this system to malfunction, essentially. We're challenging it to work in a way that it was never created to work in. And by doing that, we reach a lot of friction. We reach a lot of walls, a lot of ways in which we see very specifically that government wasn't even created to operate in a way that actually prioritizes equity. So, as an example, we have several resources that we really want to be able to get out into the most marginalized communities. We have taken those resources and as a leadership, a health equity leadership work group, really working to spearhead and ensure that those resources are equitably distributed to populations who will need them the most. That's actually the definition of equity. But the knee-jerk reaction in government is to just make it available to whoever. So if there is a testing event and, we know that there will be a bias in who actually shows up to a testing event, especially if it's something like drive-through testing that assumes several things, that someone has a car, that someone has the time and the availability to go and participate in a testing event. And the knee-jerk reaction would be, well, we're just going to provide masks and hand sanitizers there. That actually doesn't meet the point and the need for equity. And the power dynamics that we're up against in that certainly are white supremacy, and certainly our mindsets that do not broaden their horizons to see that people live in lots of different types of conditions and realities. And then the biggest, power dynamic I think that we face, especially in government, certainly is racism. Our laws and our policies and the ways that our cities and states are governed lie within this large political structure. And when you get really close up and you're able to see just how the legislative process works, just how legislators choose, what pieces of legislation to back, I think the dynamics are even more pronounced.
Thanks for sharing that, Lauren. You talked a lot about advocacy and how essentially how just the laws and policies themselves can be inherently racist. I believe that's what you were saying at the end of your remarks. And so I guess thinking about the audience that we have, what is your advice to community-based organizations, to community members, to healthcare organizations, since we have so many represented on this call? What's your advice to them of recognizing their power to change the system, to move against those power dynamics? Would you mind sharing some of your recommendations?
Sure. Well, first and foremost, I think I just want to reiterate that it is all of our jobs to work to dismantle racism in all of our positions. So there is no one person whose job it is to ensure that we eradicate racism and reach equity. We all have to chip away at it from our perspective and from our respective seats. So first, I would say to healthcare organizations, examine your policies. Examine your policies even before maybe there is an emergency or maybe even there is a need to enact those policies. An example of that is our crisis standards of care policies, right? What are the detailed, way that resources will be allocated in an emergency? Right now, I know of several other states, but certainly right now there are, some policies that certainly disenfranchise those who may come in with certain levels of numbers of chronic conditions, and that is all racialized language. And so I would certainly encourage our healthcare institutions to think about your internal policies and around resource allocation. Also think about the policies and the ways that you treat your staff. We are seeing right now in this moment so much that we all depend on each other collectively for our health, community health, for population health. When you have an employee base that does not have access to paid sick leave and to the opportunity to actually stay well themselves, that impacts your patient population and the quality of care that your patients will receive. For community-based organizations, I say, please leverage your voice and please leverage your power. I actually think that community members have much more power than people in political positions. People in political positions are there at the will of the community. And so I think we're seeing right now in this moment of extreme unrest and of outcry and protest just how powerful community voice can be. So I want to encourage all those who are a part of community-based organizations, please be loud and continue to push. And then finally, I think for those in other sort of political positions or in government, that you really need to be aware and must push actively to dismantle policies of oppression where you are, no matter where you are. State level, local level, city council, federal level matters for sure, but we're seeing just right now how important it is to actually understand what's happening locally around you and to be pushing actively to change things on the ground.
Thanks so much for that, Lauren. Really tying in that everyone can play a role, and you really need to know how do you use your power in the most effective and impactful way. And I love how you continue to tie, the need to even go back to community, since community members have so much power with their voice in the political sphere. Just thinking through where people sit, I would like to bring Dan into the conversation and really want to hear from you about, addressing some of the power dynamics you see within the system you're in.
Again, first, Artid, thank you for the opportunity. Can you hear me okay? I want to be sure we didn't get a chance to test this. You hear me all right?
We can hear you.
And it's not important that you see me, but do you see me?
We don't see you, but that's okay.
You see me now? I'm trying to change my video. Okay. All right.
We can see you now.
Okay. All right. You hear me now?
And we can hear you.
Okay. Thank you. So, all right. So I do want to thank my friend Artid Rogers for the opportunity, and Dr. Powell and Dr. Boyd for their bold voice and the opportunity to join their voices on this session today. So the issue of power is a difficult one, and as I was growing up in Mississippi and entering adulthood, I did not recognize privilege nor power in my life, but through friendships with my black friends, and especially from my African-American patients that I treated here in Mississippi, I gradually began to understand not only the social injustice that they experienced in their lives, but also the white privilege that I enjoyed in my life. Dr. King, when he used the words silence of our friends, was talking about people like me, people who were well-intentioned, people who wanted life to be better for all people in our community, but we're not using the loud voice that we needed to use to call out social injustice and to be a part of the solution. Dr. King tried to teach us that not being a part of the problem was not enough, that we needed to be a part of the solution. And that certainly is an evolution it has been an evolution for me, and I think it is for many well-intentioned white people in America. So one of the strangest experiences that I had, kind of understanding this issue of listening to the community and putting myself in a humble position to hear what other people had to say, actually occurred on another continent. I had the privilege of living in South Korea for a number of years and practicing medicine there, practicing public health there. And one of the issues that I faced in working in an inner city community was issue there that the medical issue was one of diarrhea that was, to me, with my science mind, was clearly related to the water source and lack of hygiene in human waste. And so using my science background, I put forward the right science solution to build outhouses. The community leaders looked at me and told me that what they wanted was a clinic to treat the gastrointestinal problems that they were dealing with. I continued to tell them the right science answer was to prevent the problem and not to treat it with pills. So that dialogue went on for about 6 months. I got a grant that gave us the opportunity to build the outhouses. I asked the community members to use the materials that I had secured to build the outhouses, and they continued to ignore me and to ignore building the outhouses until finally after 6 months, I not only listened, I heard what the community leaders had to say. What they wanted was a quick solution for the children in their community. And the other thing they wanted was respect. And even though I had the right science answer, I was not listening to the community. That experience helped me so much to change my ears from just listening to hearing what community members had to say.
Thanks for sharing that, Dan. I want to come back to that example in a moment. We want to make sure that everyone is being able to take away something from what the panelists are saying and some of the things that were brought up in the conversation really focus on this shift in the current ROI narrative. And I thank Rhea for being able to talk about how that actually perpetuates some of the systemic racism that we see. And we've seen different frameworks. We're just going to highlight one, the results-based accountability framework. Applying a racial equity lens causes you to ask questions around how much did we do, how well do we do it, and I think most importantly, we need to understand if people are better off. Lauren, as well as Rhea, both kind of hit on communities, particularly communities of color, being able to own and drive not only their data narratives, but their narratives in general. And so how are we including communities of color just throughout the work that we're doing, especially if the work is directly impacting them or directly affecting them? Lauren also challenged healthcare organizations to really think through how they're using their assets, including hiring, we talked about purchasing and investment to promote equity. We have been able to learn a lot from the Healthcare Anchor Network and would encourage people to go there. And hearing Dan's remarks around listening to the community and understanding the role white privilege plays in our work and systems, we may need to start thinking, or not we may, we should be thinking about developing accountability structures, even checklists to monitor and prevent bias and systemic racism in our SDOH, or Social Determinants of Health Interventions. So I want to move to the next question, and this really goes back to Anne. How does it look, especially here in the story that you just illustrated for us, really understanding that you are part of the state of power? How does it look for you to actively address power or systemic injustice, especially if you're considering yourself part of that power structure, someone who benefits from that power structure?
Yeah. So those of us who live a life of privilege have not only the opportunity but the responsibility to listen and to see and to act. It's not always easy to do. There's so many biases that are ingrained in our brain that we have to overcome, the unconscious biases that we have. And we don't always look and see things from other people's perspective. So after my several-year experience of living in Korea and experiencing privilege from a different way there, when I returned to the States and to Mississippi to an academic position at the University of Mississippi, I had the opportunity to organize a research study, the Jackson Heart Study, that looked at the causes for premature cardiovascular disease in the African American community. And, as someone who was interested in health disparities, someone who was committed to improving health disparities, I thought I knew all the answers. But that experience of dealing with professors from historically black universities and colleges, and of dealing with the community, I learned so many things, both about my own unconscious bias and about deep issues of social injustice in our community. One of the challenges that we saw in beginning that study was that though I had interest in health disparities, we were working with African Americans as our participants, and just the very issue of my background made me less than ideal to lead the study long term. And so one of the things I was asked not only to consider but to do was to recruit an African American scientist, physician scientist, to replace me as the leader. I will say, had not it been for the experience that I'd had living as a minority in another country, living as someone who looked different than the majority population, it may not have seemed logical to me that would be part of my responsibility, but it was a privilege for me to recruit someone to replace me in that role, knowing that they would have opportunities for connecting with the community in different ways than me. And I think part of the struggle for everyone who lives a life of privilege, who is part of the power structure, is recognizing the opportunities, not only to share power, but to give over power to people in the community.
Thanks for giving a practical example of what it means to yield power to communities of color, especially the Black population. How does that change your dynamic with your white peers and colleagues? Like, how does that conversation look, especially in Mississippi?
Yes, so it is a constant tension. So I want to be a change agent here in my state. I want to be a leader. And one of the things I struggle with is when to be a loud voice, when to be confrontational, and when to take a quieter voice. So in this community, many of my friends don't have the experience that I've had. Many of my white friends don't have the experiences that I've had, and they don't see things the same way that I do. And so trying to change and shape minds is not an easy thing. I think you can just ask Joe Biden what it feels like to try to lead an effort to change direction when he doesn't look like the people in the community who are suffering right now from police violence, from long history of discrimination in health and health care, and having higher rates of severe disease with COVID-19. It's not an easy conversation to have.
And thanks for giving us that reality of, that tension that if you're an ally, you may have to lean into that tension or is required to lean into that tension. I want to bring Lauren into the conversation because I think this really ties to your previous comments about being proactive instead of reactive, like everything you're talking about, especially with the Equity Leadership Task Force in Virginia. You made a point to say that it was proactive. And I'm just wondering, just like Dan is having to think about being proactive to yield power, to think about his white privilege, how should our audience think about being proactive in tackling systems of inequities rather than reactive? Would love to hear your point of view on that.
Sure. And I thank you so much to Mr. Jones, to Dr. Jones. Thank you. Appreciate that perspective, and appreciate you being candid about that experience. When we thought about the need to be proactive, especially in this moment and in this unprecedented public health emergency that we find ourselves in, I think one of the things we kind of have to do is we also have to be a little bit clairvoyant. Like, we also have to kind of look forward and think about what are the inequities to come while we're also tackling the inequities right in front of us. And so I think that was the impetus for really creating Virginia's Equity Leadership Task Force. This was something created before a state of emergency was even declared in Virginia. Virginia also has the country's first chief diversity officer, and Dr. Janice Underwood, who in her excellent leadership was really very forward-thinking about how COVID-19, before we had any data, before we even knew how widespread it was, before we knew it was going to be a pandemic, and really thinking about this is going to have an impact on Black and Brown communities, and we need to think about that up front. And so the Equity Leadership Task Force was created in response to really wanting to make sure that there is equity lens deeply embedded within every facet of this response. And in doing so, we were also very, very thoughtful about where does this body belong? So government has like pages and pages of ridiculous like hierarchies. Organizational structures can go on for pages. Like, it's very, very hierarchical. And so in that, what often tends to happen is that equity gets pushed to a corner, right? A health equity work group becomes this thing that's at the very bottom of the totem pole. And so we were very, diligent and bold about the fact that there needs to be something on the highest levels that reports to the highest entities. And so that is exactly what it is. The Health Equity Leadership Task Force reports directly to Unified Command. Unified Command is made up of emergency management personnel as well as, the lead agency in whatever emergency it may be. In some of the work that we're doing, we're really thinking a lot about the role of even communication. So because of the Equity Task Force, we've really been able to respond better to COVID than I think we would have responded without this important group. And we're thinking more about what is our role in driving public health campaigns as well as communication at this time, and how we communicate. So an example of really being very proactive is even before we find ourselves in the moment we're in now, this intersection of experiencing COVID and also experiencing the heinous murder of George Floyd. We thought very proactively about, okay, we're asking everyone to wear masks. How could that potentially backfire? Is there a population among us for whom wearing masks could potentially be problematic? Yes, there is. And so we wanted to be proactive in our messaging campaigns, our public health campaigns around that. We wanted to understand better how we can encourage our Black and brown community as well as white people to wear masks, but also not see Black bodies as being weaponized or somehow a greater threat because of wearing a mask. And so we have actively embarked upon a public health communications campaign to really try to soften the perspectives of those who may see Black and brown people in masks as an additional threat. And that way we're trying to be proactive in thinking about how do we mitigate the impacts of COVID-19 on communities of color while also protecting the very real fear, the double fear of not only getting COVID, but also potentially being killed, arrested, looked at with, side eyes and looked at crazy because you are a Black person wearing a mask. And so we've embarked upon a communications campaign around that, very publicly talking about this message, very publicly talking about the double threats for Black and brown people, and the underlying current of racism that is perpetuating that.
Thanks so much for that, Lauren, especially bringing a real example from just our current situation within the pandemic and, eloquently tying it to an inequity or an injustice that we're seeing the Black community facing right now. And just that level of proactiveness is, as you've been saying all along, needed to tackle structural racism, to tackle white supremacy. And when I think about the work that social determinants of health interventions are intended to do, it's supposed to be proactive. Many of these interventions are focused on individual resource navigation. And as Lauren has been highlighting, consistently, the intentionality that's needed to push systems to tackle disparities and inequities. Rhea, I want to bring you into the conversation to just provide our audience with insight on how we can be proactive when it comes to individual resource navigation interventions that are often associated with the social determinants of health sector, if you wouldn't mind.
Absolutely. So in some of my work as the Chief Medical Officer of San Diego 211's Health Home, we started having conversations with the navigators about what it feels like to be that frontline person who is supposed to provide this individual intervention when there's a systematic or systemic problem at play. And this has come up most recently around COVID, where a number of our navigators shared that, they're sitting across from somebody on the phone and there is no resource to refer them to. As testing capacity has increased, there are more places, clinics, for example, that you can send people to. But at the very beginning of this, people were calling with concerns and there was nowhere to go. They needed a housing referral, and the city had not yet coordinated a response for the growing numbers of homeless in San Diego. And so on the front lines, they were really just weathering the anguish and anger, honestly, of San Diegans who needed something, and the city and honestly our governor said, if you need something, call 211, and then they call that number, and then that service provider has to say, actually, that service is full, or actually that service doesn't even exist. So I think I bring that up to say there are limitations to trying to dole out interventions at the individual level if we don't also have at work a process to make sure that you have the resources available to give out to folks. And for many states that are experiencing a lot of economic downturn after COVID-19, I think their budgets are going to shrink, and there's actually going to be even less resources available as that need grows. And so that mismatch means organizations have to be thinking both at the individual level, how do we take care of the crisis needs of the populations we serve, but then how are we also advocating to make sure that whatever dollars are available are feeding back in so that we can continually be responsive to those communities.
Thanks so much for that. As we move into our next question, I think some of the takeaways that these three panelists have given us is first just white allies being able to yield power to Black and Brown community members and to really abide by this principle of, nothing about us without us. We also have to create processes and structures that allow health systems to proactively hear and understand community priorities and nuances. Just like Lauren pointed out with the public health issue with COVID-19, the COVID-19 pandemic, understanding how that may impact a community of color, in this particular example, Black men. And then what Rhea has really pointed out is moving social determinants of health interventions beyond the resource navigation. Not saying that it's bad to do it, but to make sure that we're thinking about the policy implications as well. So I think two of you have at least touched on COVID. And so that really ties into our last question. Just what do you see are the emerging opportunities for systems change or policy work during and post-COVID-19? And Rhea, I'm going to ask if you wouldn't mind starting for us.
Definitely. And I'll say also that I apologize. I do have to jump off a bit early from this call, so I won't get to answer everyone's questions. But if people have further questions, feel free to reach out to me on Twitter. My Twitter is just at Rhea Boyd, MD. I think when we talk about the opportunities for policy change that are coming up right now, I think as you open this artier, and as you said, Lauren, we have to talk about what all of our systems are doing about the violence of our police state across the nation. I think we have to think about how are our organizations supporting protesters so that they can create the civil unrest that can push new policies at the federal and local level. For healthcare organizations, that may even just look like setting up medic tents at protests so that if people need water, if people need food as it gets hotter outside, in the unfortunate event that there's any injuries that occur during a protest, that people can get what they need right there on the street. I also think it means hospital systems must say something about the health impact of police violence. And I'm jumping off this call to next talk about that very topic on another call. Police kill people, right? This is squarely within our domain to think about. They kill people, and we know police violence disproportionately affects Black, Indigenous, and Latinx communities. This is a core racial health inequity, and it's one for which our systems have been entirely silent. The American Public Health Association has had a policy statement calling police violence a public health issue since 1995. But most health systems have done little about it. Most public health departments don't have the jurisdiction or don't have the power to negotiate with police departments to shape how they engage with communities. There are models that can work. I'll just mention one, crisis intervention teams. Crisis intervention teams are when people call 911, but they are calling because they have a domestic dispute or somebody is having a psychiatric crisis. Instead of sending a police officer, which many municipalities send, crisis intervention teams are composed of healthcare providers, social workers, mental health professionals who are prepared to de-escalate these scenarios, provide any needs to any other folks in the household who have been affected by the crisis or dispute, and do so in a way that never escalates to violence. So I think an emerging opportunity is for us to think very critically about what we're doing about policing because we haven't done enough. Thank you all so much for being on this call. And for those who have other questions for me in particular, I look forward to talking to you on Twitter.
Thank you so much, Rhea. What's also really interesting is just COVID-19, the response for COVID-19 looks so different depending on where you are in the country. And I think about Rhea, who's talking about a perspective in California, and then I look at the direct opposite when I look at Dan being in Mississippi. And so I'm wondering from you, what are emerging opportunities that you're seeing for systems change or policy change work during and post-COVID-19?
COVID-19 and police violence as our problem and not your problem, not the problem, but our problem. The words silence and inaction, those seem like gentle words, but those are dangerous words. The violence that we see now in the streets is a result of silence and inaction on the part of people in power and people of privilege. So one particular opportunity I'll point out right now in the COVID crisis, state budgets are going to be hurting and are going to be cut in most states. And then there's a huge influx of federal money that's coming to states, and decisions have to be made both about those cuts in state services, and decisions have to be made about the use of the special funds that are coming from federal sources during COVID-19. It is a huge opportunity at the state level for states to consider issues of past injustice and to think about opportunities for enhancing healthcare opportunities and enhancing educational opportunities in communities of color and communities that have been disadvantaged in the states for a long time. I hope that our political leaders will see this as an opportunity for change.
Yeah, I see Lauren shaking her head a lot when you're speaking.
That was the word. Thank you. Thank you.
So I would love for you to chime in as well, and then we'll open it up for Q&A.
You are so on point with everything you just said. You're so right. In fact, Virginia is reconvening the legislature, because these decisions have to be made prior to budget changes, and budget decisions have to be made prior to the fiscal year beginning, which is July 1st. So to everyone on these calls, please pay attention to what's happening in your state. The budget cuts are absolutely being made, and we always unfortunately, it feels like those cuts are made from programs that have impact to Black and Brown communities and will disproportionately, make things worse in those communities. So that was such an important point. And then CARES Act money, coronavirus aid and relief money from federal dollars are also pouring into states to the tune of $3 billion a state, something like that. So, to those in community-based organizations, everyone on the call as a free citizen, we should be asking about where that money is going and who it's being funneled towards. So I think those were excellent points to be made, and you're so right about this is a chance to really right some past wrongs. And right now it is politically incorrect to say that you're racist, but to still perpetuate racist tendencies and racial mindsets. It happens every day. And this is a moment that we have to remind our leaders, you can actually start to move towards righting some of these past wrongs. And I will say, in a very current event, just about an hour ago, the governor here in Virginia just made a major announcement that they are taking down the Robert E. Lee Monument. One of the oldest Confederate monuments, I think, in the country, and the first one that was erected here in Virginia, one step of many more that are hopefully need to come. But a true symbol of, Richmond and Virginia is the cradle of the Confederacy. This is ground zero for Confederate mindsets and the perpetuation of slavery and racial ideals and racism. So that is really, really big. But to some other points, around opportunities for system change or policy change work during and post-COVID. I think we should not overlook contact tracing. Contact tracing is a really, really big thing. So we think about all these protests that are happening. I'm so glad Dr. Boyd spoke to that. We absolutely need our hospital systems and public healthcare systems, quite frankly, to step up and to provide resources to protesters so that they can demonstrate safely. There's no reason in my mind why we shouldn't be giving out masks. We know where people are going to be. We should be stepping in and intervening in that way. And all of those who are in positions of power in hospital systems, this is your opportunity. This is it. We know that there are large groups of people. She's absolutely right. It's going to get hotter. We should be providing, PPE and assisting in that way. In addition to that, because we're going to have, so many people continuously gathering, and I quite frankly don't think there's any end in sight, there is a high likelihood that there will be more cases. When you think about the increased need for contact tracers after this, all of the ways that they're going to have to intervene to potentially let people know that you may have been exposed. So the need for contact tracers, but also equipping contact tracers with the resources to actually do social determinants of health intervention. So not just allowing a touch point, which by the way, it should be a physical touch point. I don't really quite understand how people plan to operationalize contact tracing without making physical contact. That's really confusing to me. A lot of these larger companies are perpetuating this thought that you can do remote contact tracing. Essentially, I could stay in my house, call you or text you and let you know that you may have been exposed to COVID. I don't know about any of you, but I don't answer calls that I don't know. And I don't respond to texts from people that I don't know. And I especially would not respond to a government-based call or text. So to the extent that we plan on doing contact tracing without making contact is very problematic, questionable to me. And, I think that we should be thinking about, one, how do we leverage community health workers? And how do we leverage people who already have strong ties to the community, who are people of color, who have also disproportionately been impacted economically by COVID-19? How do we leverage those people to go out to do contact tracing and to actually make face-to-face contact with people very safely, of course, with PPE and all other precautions taken, but also using that moment to say, hey, we could actually, I have someone with me, we can test you right now. And by the way, do you need some food? We can sign you up right now and make sure your food gets delivered. Also, do you need any other social service assistance? We should be leveraging the opportunity to do all of that at once.
Thanks, Lauren. I love the passion that was coming out, really talking about understanding the moment that we're in. I think all three of you did that, and how we can leverage this for good. I want to go to some of the Q&A that's been populated throughout the chat. But before we open it up, I really want to thank you three, Rhea and Lauren. I know Rhea left, but it's extremely challenging, and I'm stepping into being a Black male, but it's extremely challenging to talk about justice and racial equity and systemic oppression and racism at this time. And I just remember being taught about systemic racism, and we often quote Martin Luther King Jr. a lot, but I'm going to quote Malcolm X when he talks about not having a chip on his shoulder, that he has a foot on his neck. And that was how systemic racism was taught to me. And after seeing the heinous murder of George Floyd, where we actually saw a knee on someone's neck, Black people are often put in the position to describe what it means to experience systemic racism and also give recommendations on how to address it to our white colleagues. And I don't think sometimes people understand the weight and the burden that is. So I just want to thank you two for doing that. And Dan, I want to appreciate you for leaning in to discussing, what is lifelong work of becoming an ally, and the active role white people must take in dismantling white supremacy. So with that, there are a couple of questions I wanted to highlight. One was really talking about data and the use of data to promote systems change to dismantle white supremacy, and just wanted to get your thoughts on what role you saw data playing in this work. And Lauren, we can start with you.
Sure. Thanks for that question. I think data, I saw a quote somewhere like data is like the modern day gold. So it is something of great value for sure. And I think data certainly plays an important role. Like we leverage a data system to really help guide where and how to distribute resources, like masks and hand sanitizers to the most at-risk population. So I think data can certainly be leveraged for good. But I have a word of caution about data. I think too often we spin our wheels. It is a manifestation of white supremacy to constantly have to, justify disparities and justify inequities. We are constantly, pushed to show the numbers of how inequities are affecting people. I feel like we have done plenty of research. I feel like we have, and that's no shade to researchers, like continue to do what pushes you and what motivates you. But I think people sometimes leverage data as an excuse to not actually act. And I think we have to be very cautious about that. I think we also, especially in the lane of social determinants of health, I've seen some major and very expensive systems coming out about really connecting social determinants of health, serving organizations with hospitals and things like that. I think that those can be really interesting, but I think we have to pause and push ourselves to think about who is this actually helping. Sometimes the money we put into data collection, the money we put into research, the money we put into continuing to define a problem that we already know exists, detracts money and detracts resources away from actually making change. And we really have to leverage data to move to action.
Great point. Thanks so much for that, Lauren. Dan, wanted to see if you had anything you wanted to add to that.
It's not the end all for these issues. So when we were organizing the Jackson Hart study, data was important for convincing the folks at the National Institutes of Health to give us the funding that we needed to do the study. But as the results of the study are available, and I use that when I go to try to bring political change at the state house in the city, and I find that those rational, objective tools are not very effective in the political sphere, and especially in the state house in Mississippi, using data to talk about the poor people does not move the needle on getting action taken, unfortunately.
So really talking about, not being afraid to go beyond that, not allowing that to be your stopping point, that we have to do more. And I love what you were saying, Lauren, too, as we invest in social determinants of health interventions that may be connecting different groups to pull data, that we have to understand, are we actually touching the people in need? And I think that leads to another question that was posed, which was really just giving advice around, if we're doing care in the community, we need to include the community. So give suggestions on how you reach the community. I think that will be helpful for our audience to hear.
So I'll begin by going back to the example of the Jackson Hart study. One of the keys to interacting with the community is to have people in your leadership team who understand the community, who look like the community, who have the language of the community. That's critically important, I think, in having the community be a part of making decisions about their own health care.
Yeah, I would absolutely second that. And I think, in addition to that, we should really make sure that we're including community voice up front. Quite often we wait until decisions have been made to include community voice, and that negates really the power that comes from community perspective. So I think that's super important. I think, it is kind of challenging in this virtual environment to do community-based activities because we have to rely on technology so much, but it's not impossible. And so the Commonwealth of Virginia and the Health Equity Leadership Task Force, we've led several community conversations virtually with the faith-based community, with the LGBTQ community, African American community, the Asian community, Latinx community, specifically trying to speak to several of the challenges that are specific to those communities. And so I do think, where there is a will, there actually really is a way. And more importantly, this moment, more than anything, I think should remind us of the need to have ongoing relationships in the community. So we can't wait until we're in a pandemic to suddenly start reaching out to faith leaders. That it doesn't work that way. Like, we have to have a relationship and a bi-directional communication relationship, one in which we're not always just dictating what needs to be done to people in the community, but we're also hearing from them, like, what do you need and how can we help you?
Artia, if I could add on to that for a moment, one of the saddest postings on Twitter that I've seen in recent days was a photo of former NFL quarterback Colin Kaepernick, in his kneeling position, looking at the camera, and the caption was, "You just wouldn't listen, would you?" I think what that message was saying. You wouldn't listen, so here we are with our louder voice with violence in the streets. You got to listen. You got to listen to the community.
Shifting a little bit to, I guess, just health systems again, do you have any examples of successful structural inequity system change relative to shifting health disparities? And the question really talked about documenting things for decades and not seeing them change for the better. So I guess this person is really wanting to understand evidence-based structural systems change practices. So I'm leaving that question there. I think that in reading the question, there seems to be a need to understand how do we understand if an equity-based systems change practice is equity-based, and where can they get resources like that?
Dr. Powell, you want to take a first shot at that?
Yeah, I can take a slight shot at that. I will say that, that's not exactly, I don't have the fullest expertise in that, and that's actually a great question. I would like to know more about it myself. But I do think that there are some hospital systems, Kaiser is one that comes to mind, that it really do try to embody under the leadership of the late Bernard Tyson, who really led the path and trailblazed the way in embracing what it means to care about the social determinants of health in everything we do. From the way that employees are treated to the way that even, decisions about expansion are made. I was on a call earlier this week where someone said he would think about, even if we are expanding the hospital system, let's say they're building a new building, where they would build that building, because that building would provide more jobs for the community, that would provide more opportunities for folks. And so I think that is one way to think about real systems change. That is, I think hospital systems have to challenge themselves to think about, your job, it's not just your job to make people, like to fix people from whatever ailment brought them to the hospital. It's your job to create wellness for the entire community that surrounds you. And so that extends beyond the four walls and goes and trickles out into the community. And so the question really becomes like, how are our hospital systems embodying perspective of systems change that embraces equity beyond just the patient population, but out into the community as well?
Thanks, Lauren. Dan, you have time for like a 1 to 2 word response, just because 10:15 is about to hit us. So it has to be really good.
Yeah. So I'll just say as quickly as I can, you have to be very intentional to bring about change. There are many, many federal regulations in Medicaid and Medicare that make it difficult to bring equity at the interface between the health system and the patient. And I'll just say healthcare administrators have to be very intentional and very creative in finding ways to bring equity in their healthcare systems.
Well, thank you all for that, and thank you to everyone who participated. There is more information. We'll be sending out the recording. If you have any questions, you can email us and at network@healthleadsusa.org, and stay tuned for our next webinar that will focus on evaluation. So thank you all. Hope you have a great day, and hope to talk to you all soon. Bye-bye.